Hello, I'm Steve Buck, Chair of the Department of Psychology here at the University of Washington. The lecture you're about to see is part of our annual Alan Edwards Psychology Lecture Series. Professor Edwards was affiliated with the Department of Psychology for half a century until his death in 1994. He was an outstanding teacher, researcher, and writer who introduced new statistical techniques that are credited with changing the way modern psychological research is conducted. Alan also permanently enhanced the intellectual climate of UW Psychology by endowing the Alan Edwards Lectureship, which since 1999 has brought an impressive list of renowned psychologists to the UW campus to interact with faculty and students. Now, the annual Alan Edwards Psychology Lecture Series presents the excitement of psychological research and its tangible benefits to both local and national audiences. The lecture you're about to watch is one of a pair given back-to-back that matched a UW Psychology faculty member with a visiting researcher to talk about a topic of great public and scientific interest. Good evening. I'm Steve Buck, Chair of the Department of Psychology here at the University of Washington. Welcome to this evening's continuation of the Alan Edwards Psychology Lecture Series. This series is presented by the College of Arts and Sciences and the University of Washington Alumni Association and is funded by a generous endowment from Alan L. Edwards. The topics in this series illustrate how psychological research serves humanity. The University of Washington receives more research support than any other public university in the nation. The psychology department alone receives nearly $10 million annually in research support that helps us advance our knowledge of basic science, directly serve people in our community and around the globe, and train our undergraduates and graduate students. Tonight's lecture addresses suicidal individuals, evaluation, therapies, and ethics. Our first speaker is Dr. Barbara Stanley. Dr. Stanley is the director of the Center on Intervention for Prevention of Suicide and a research scientist in the Department of Neuroscience at New York State Psychiatric Institute. She's also on the faculty at Columbia University and the City University of New York John Jay College. She has contributed over 80 scientific publications on research ethics, suicidal behavior, self-injury, and borderline personality disorder, and has been recipient of several federal and private foundation grant awards. Dr. Stanley has long contributed to the national discussion about ethics and research on suicide, having been founder and first president of Applied Research Ethics National Association, on the board of directors of Public Responsibility in Medicine and Research, and chair of the Committee for the Protection of Human Participants in Research for the American Psychological Association. Dr. Stanley has served as a consultant in developing guidelines for protection of human subjects and inclusion of suicidal patients in treatment trials for the National Institutes of Mental Health, the National Institutes of Health, and the American Psychological Association. She's also currently the president of the New York Metropolitan Area Regional Chapter of the American Foundation for Suicide Prevention. Please help me welcome Dr. Barbara Stanley.
Thank you very much for inviting me here. The title of my talk, as you can see, is Developing Effective Treatments for Suicidal People. Why are we so far behind? And the risk of protection. So before I start my talk, I really would like to honor Alan L. Edwards, who wrote this textbook. And I want to just say that I spent a summer with Alan Edwards, although I never met him. Before I started graduate school, I got a letter in the mail from my program saying that for students who wanted to try to opt out of the first level of statistics, they could study this textbook and try to pass the exam. And so I spent the entire summer reading Alan Edwards' textbook, which was a great textbook. And when I was preparing for this talk, I pulled out the textbook and looked on the inside, and on the inside jacket where his dedication was, this was a wonderful quote that I thought that he wrote. "To test a hypothesis is relatively easy. To find a significant hypothesis to test is much more difficult." So I want to thank him, and I'm very honored to be here. And the other person that I want to thank is Marcia Linehan for inviting me to be here. I have the great pleasure over the last few years to have Marcia as a colleague and to develop a wonderful friendship with her. And as you will hear, if you haven't heard her speak before, she is not only a wonderful, talented clinician, but one of the true creative thinkers in our field, and I feel honored to know her. So, I am going to talk about why we are where we are in terms of helping prevent suicide. So if we look at suicide statistics, we have in the United States more than 30,000 people die by suicide each year. It's the third leading cause of death in young people, and 10,000 more people die by suicide in the United States than homicide every year. And of course, homicide catches the front pages of the newspapers, but suicide takes lives of many more people. And truly, these figures are probably a great underestimate. Sometimes it's difficult to determine if a death is a suicide, for example, automobile accidents that are suicides. And sometimes coroners will not reveal the truth to families in order to protect them. So these figures, I'm quite sure, are an underestimate. And if we look at suicide rates in the United States, if you put those four lines together, you will see that from 1975 on, that the rate has been relatively stable. So if you look at what we've been doing in terms of preventing suicide, we haven't been doing that good a job. Things have stayed the same. Despite all of the progress in science, we pretty much stayed where we were. And I want to, and over the course of my talk, I'm going to contrast this with AIDS and HIV and what has happened on that front. If you contrast it with AIDS, if you look at the figure here and the downturn in the number of deaths by AIDS, you can see that we've done a much better job at preventing deaths from AIDS. And so why is that? And so you have to begin to wonder what is going on that somehow we've done a much better job, a much faster job at diminishing the number of deaths by AIDS. Why? So now I just want to turn for a minute to look at suicide attempts. Often in the field, people talk about suicide attempts only as important as markers for future suicide. But suicide attempts in and of themselves are a bad thing. They carry a great morbidity. People lose jobs over it. They get hospitalized, days at work. And so if you look at this, there's 3 to 10 times more suicide. For every suicide, there's 3 to 10 times the suicide attempts. And this is probably an underestimate. Many attempts never come to the attention of mental health professionals or physicians. Many attempts never come to the attention of family members. So there are suicide attempts that people make that nobody know about except the person who's made them. And when we look at what are risk factors for future suicide attempts are the greatest risk factor. So when we think about youth, and I just am drawing your attention to the bottom line here. If you look at the bottom line there, this is a survey that is done for kids in grades 9 through 12. And according to this survey, anywhere from 7 to 8.5% of children in these grades attempt suicide every year. Now, this is their self-report, and so what they're calling a suicide attempt may not be what we're calling an attempt, but in their minds, they're making a suicide attempt. And if you look at the number of kids who are considering suicide, you're talking in the 16 to 20-some% every year. So this is not a small problem. So is suicide a random occurrence? Most people who commit suicide have at least one psychiatric disorder that's serious. People who commit or attempt suicide have considered it typically over long periods of time. Suicidal behavior runs in families. So if somebody has committed suicide in a family or has attempted suicide, their children are at greater risk for attempting or committing suicide. And there was an article, for example, that David Brent and colleagues wrote with us about looking at offspring of attempters. They had a 6-fold increase of risk of suicide attempts relative to offspring of non-attempters. And so this is in the context of a family where the non-attempter mother had depression too. So it isn't just like if you are depressed, your children are at risk. No, if you are a suicide attempter, that carries a special risk. So if you put these factors together, you can see it's not a random occurrence. And so if it's not random, then we have a good chance at preventing it. So why, again, are we not doing a better job of this? So there's 2 paths that we can think about as ways to prevent suicide. First is large-scale prevention efforts. And there are a lot of these: public service announcements, hotlines, screening individuals for suicide risk. And the second, which is the area that I work in, is treatment of individuals known to be at risk. So this is who is at risk. This is people who have made prior suicide attempts, people who have chronic suicide ideation, people who engage in other forms of self-injurious behavior, such as non-suicidal self-injury. So we have these 2 paths. So where does it take us? We have over 40,000 articles published on suicide from 1966 to 2006. So that's a good amount of articles, right? There are about 300 reports, some small open trials and case descriptions on the treatment of suicidal individuals. But around only 30 articles that are doing randomized clinical trials of affected individuals. That's not a large number when you consider the number of articles that are published in the area of suicide. And most of these trials are psychotherapy or psychosocial interventions as opposed to medication trials. So there are even fewer of those. So, okay, so we have 40,000 articles on suicide. So what do we do when we turn to AIDS and HIV? That field is so far outstripping what we're doing in suicide. Now, given that suicide has been around forever and HIV is relatively new in terms of being diagnosed and known, over 200,000 articles on HIV in the same time period. 50,000 of them have the United States, so in the title. And over 137,000 on AIDS. And well over, and this is an underestimate, 100 randomized clinical trials. So if we look at the difference, you have to wonder why, what are the people who are working in the field of HIV and AIDS doing that people who are working in the area of suicide are not? And I'll talk a little bit about that later. So, why are there so few treatment trials with suicidal individuals? Well, there is a culture in the mental health field of researchers, clinicians, reviewers of research, which are the institutional review boards, of this notion of first do no harm, which is interpreted as give the best available treatment to somebody who is suicidal, whether it's proven effective or not. You cannot possibly withhold it from somebody who is suicidal. And so that's the kind of climate that we operate within. So I wanted to step back for a minute and just give you my own little personal history of this. When I first started doing work on suicide interventions, which is not that long ago, I started to, the way that I got into this is I was doing a behavioral study, and a biological study in people who were suicidal. And I decided that really what I wanted to do for them, instead of paying them for participation in my study, is I wanted to offer them treatment. And so my idea for this was, okay, I'll just go to the literature and find the best treatment. And I went to the literature and I looked and I looked and I looked, and I really couldn't find anything, and I was horrified. And eventually I came across DBT. And so that actually was the way that I entered this field. So when I went to colleagues and sought expert opinion on this, this is what I was told about doing a trial on suicidal individuals. It's neither clinically practical nor ethically justifiable to include actively suicidal individuals in a treatment trial. End of story. Then I sought the opinion of another colleague. I actually presented this. We have these center meetings every now and then, and presented it before a group of peers because we were supposed to talk about what our ideas were for future research. And so I presented my idea for a trial working with suicidal individuals, and a very esteemed colleague said, "Don't you think that others have thought of doing trials with suicidal patients? It simply isn't possible." So I wasn't deterred, but this is what is happening when people talk about doing trials with suicidal patients. That the risk, which are those big bars over there, seems in their minds to outweigh the potential benefits of doing these kinds of trials. And so it ends up in a very risk-aversive environment. And so the Institutional Review Board, I think, operates within this climate. And so I'll give you a couple examples I just picked out a couple that happened relatively recently. A pilot psychotherapy project using a therapy effective in depression to determine if it was helpful in treating adolescent girls who cut themselves in a non-suicidal way was proposed to the Institutional Review Board. And their opinion was that no patient with suicide ideation may be enrolled in the study. In other words, there was probably going to end up with a universe of one patient because the two things track together so frequently. But they're quite insistent on that. Another example, a trial comparing two medications for depressed suicidal patients with history of suicide attempts. The opinion was that if a patient made a suicide attempt, he or she must immediately be removed from the study and given the indicated treatment. So what exactly was the indicated treatment? And they didn't have the answer, but they said, well, clinicians would know what that would be. Clinicians would know. So how is decision-making made? What do they do? First of all, the focus is mostly on the safety of the individuals who will be in research. So the focus, and rightly so, that IRBs are in the business of protecting who the subjects will be. And so that makes sense from their point of view. They're not as concerned, and this is not part of their concern typically, as much with the improvement of the affected population. And so I guess what I would say to you is that somebody has to be. And it necessarily results in potential risks to participants given the most weight. And so it's a risk-aversive approach. So how does the rest of medicine handle treatment trials with individuals who have a life-threatening illness? So if you take my colleague's comment, if you could imagine in the rest of medicine that it would go something like this. It's neither clinically practical nor ethically justifiable to include individuals with a potentially life-threatening illness in a treatment trial. Would that ever be said? So would there be oncology trials? Would there be AIDS trials, HIV trials? So, okay, so if we do not have trials that specifically target people who are suicidal, let's turn to an alternative. And so the alternative would be just including the affected population in trials of disorders in which suicidal behavior is either a diagnostic criterion or where it occurs in high frequency. So, for example, in major depression and borderline personality disorder, you have high percentages of people who attempt to commit suicide, and in fact, in both of those disorders, one of the diagnostic criteria is that the person is suicidal or has made a suicide attempt. Or in disorders where you have a high rate of suicide, like schizophrenia or bipolar disorder, where in bipolar disorder the suicide rate approaches 20%. So that's the alternative. So in other areas, if we kind of go back now to looking at medical research, are the most ill segments, which I would consider people who are actively suicidal, segments of the populations included in trials of medical disorders. In oncology trials, the most ill are often the first group that we study, not the first group that we exclude or the last group included. Individuals are excluded often not because they're too ill, but because there is no prospect of benefit. In other words, there is no hope for them to benefit, and so they are not included. But in psychology and psychiatry, we have a different metric with psychiatric disorders. So I thought, okay, so maybe I'm missing something here, and maybe patients really are included in these trials. So this is what we did. We looked at depression trials of antidepressants, and we reviewed all the inclusion-exclusion criteria for adult trials from 1984 to 2001 for fluoxetine, citalopram, paroxetine, and sertraline. And so we wanted to determine whether patients with suicidality and disorders in which suicidality occur are frequently represented in treatment trials. So we reviewed the inclusion-exclusion criteria, and we looked for suicidality, alcohol use, and dependence. We looked for that because alcohol is a frequent co-occurrence in suicidal behavior. Also, alcohol is often used at the time of a suicide attempt and suicide. So when we didn't find the answer in the methods, which we often didn't, of the articles that we surveyed, we contacted the authors of these articles. And so we reviewed a lot of trials, and you can see that a lot of trials excluded whether they included people who were, they were silent on whether they included people who were suicidal or not. And so we were able to, by contacting authors of the trials, get information for most of them. So here's what we found. In fluoxetine, Prozac, 2 out of studies out of 28 included people who were suicidal. 4 out of 24 studies with paroxetine, 1 out of 10 for citalopram, 1 out of 15 for sertraline. In other words, 10% of the trials allowed some level of suicidality in their patients. Now, this doesn't mean that patients were actively suicidal. It meant that they might have permitted a small amount of suicide ideation. And so you can see that the idea that, well, patients were just being routinely included is not really true. So if we look at alcohol and suicide, for example, alcohol is a major risk factor for suicide. 1/3 of all suicide deaths each year involve alcohol. In other words, the person drank alcohol prior to the suicide or used it as part of their suicide attempt. So clearly, every year, 10,000 deaths from suicide involve alcohol. So, did alcohol use disorders get included and excluded in these trials? They were included a little more than suicidality was, but they were mostly excluded. So this doesn't say that, now if we take the comorbidity of both alcohol and suicidal, there are 2 trials that do that. So what does this tell us about antidepressants? And I'm going to come to what has happened recently with the FDA as a way of kind of bringing this around. What this tells us is that we know a lot about a relatively circumscribed type of major depression. We know little about the depressed alcoholic and little about the acutely suicidal depressed and alcoholic. So by systematically excluding people from these trials, we don't have knowledge about them. We know even less when the problems co-occur. And what I would say is it's problematic to generalize to the population who will be receiving treatment in the community. So, for example, if we have done a trial, or all of the trials, in depressed people who are not suicidal at all, how do we know what's going to happen when we give it to somebody who is suicidal in the community? Or is it going to make them better? Is it going to make them worse? And I'm focusing on medication here, but actually in psychotherapy trials, the exclusions are very similar. So this brings us to the FDA. In October of 2004, the FDA released a black box for SSRIs, antidepressants, for children and adolescents. And so the release went, today the Food and Drug Administration directs manufacturers of all antidepressant drugs to revise the labeling of their product to include a boxed warning and expanded warning statements that alert healthcare providers to an increased risk of suicidality in children and adolescents being treated with these agents, and to include additional information about the results of pediatric studies. So what does this mean? What did this mean? Did they go back and look at the trials and find that many kids committed suicide during the trials? No. In fact, there was not one suicide that occurred in these trials. But this was the information that they had to go by, and I'll come back to this in a minute. So this is actually the black box warning that doctors talk about all the time. And in fact, it is a black box, and it goes on the package insert, and it goes in the PDR. And this is what it read, and it reads now. And if you look at this, when there is a black box, it's clearly identified to the doctor as something to take notice of, and that's why it's a black box. And so people were concerned that there would be a chilling effect on medication prescription for this population, and worried that kids who needed treatment would not be getting treatment. Then eventually, in December of last year, the black box warning was extended to young people, up to age, I think it's 24. So what information did the FDA use to make these determinations? So they took adverse event reports supplied by investigators. There were no well-defined criteria for determining what a suicide attempt was, and no systematic collection of suicide data. So I happened to work on this, the Reclassification project, where the FDA commissioned a group of us at Columbia to take all of the adverse events that were reported for these pediatric trials and to reclassify them. And so these were all reviewed and coded because they were concerned that things that were attempts were not really being coded as attempts. So these were some of the events. I'm just going to give you a little sampling of the events that were that we saw. So there was a 10-year-old boy who exhibited symptoms of personality disorder of moderate severity, and he was discontinued. One day later, he attempted to hang himself with a rope after a dispute with his father, and the adverse event label was personality disorder. There was no mention of anything suicidal. Adverse event 2. A 14-year-old patient took 11 tablets impulsively after an argument, then went to school. The patient denied that it was a suicide attempt. It was labeled as a medication error. I'll say. A 10-year-old boy had an argument with his stepfather. He wrapped a cord from a mini blind around his neck, saying that he wanted to kill himself. It was labeled as hostility. So lest you think that it only goes in one direction, A 14-year-old female patient was reported to have engaged in an episode of automutilation where she slapped herself in the face, and it was labeled as emotional lability and a suicide attempt. So these are the data that we had to go by. This is what the FDA had to look at to classify adverse events, to determine whether these adverse events meant that there was an additional risk of suicide in this group. So what are the lessons learned from this? The quality of the conclusions are only as good as the quality of the data. And that's the plea that I would make. There are no randomized controlled trials of antidepressants in suicidal adolescents, many of whom are prescribed antidepressants in the community. So we still don't really know if antidepressants given to suicidal adolescents make them more or less suicidal. We have ideas about it from looking at pieces of data, but the gold standard in our field is a clinical trial that's randomized. We do not have that. Why? So, recently, there was the Center for Disease Control release of information that says that the suicide rate rose more than 18% in those 1 to 19 years old in 2004. So this is after the black box warning. And so what do people draw as their conclusion? The rise occurred at the same time that the Food and Drug Administration mandated heightened warnings on the labels of selective serotonin reuptake inhibitors. And it goes on. Stricter warnings on antidepressants may have caused doctors to prescribe them less frequently to children, leading to higher suicide rates, some experts say. Again, child and teen suicide rates rose for the first time in more than a decade. Many psychological experts said the stronger warning labels led to a drop in the number of prescriptions for antidepressant drugs, and this is to blame. And further, now, one of my colleagues was quoted as saying this: "I have no doubt that there is such a relationship." Says Dr. Nemiroff, "The concerns about antidepressant use in children and adolescents has paradoxically resulted in a reduction in their use, and this has contributed to increased suicide rates." So this may be completely true, but we actually have no data on this. And so we are kind of doomed to continue repeating this. Several years ago, we had a Prozac story where Prozac came out, and then it was followed very quickly by a few case reports that said people got more suicidal on Prozac. And we kind of just sat there with this argument back and forth in the field. Did it encourage suicidal behavior? Did it not? Did it protect people? And we've sat there and sat there and sat there. So what I would say is that risk aversion has a cost. Part of the reason why the field has stayed where it is that people are afraid. Protection by exclusion may not actually end up being protective. So we're keeping people who are suicidal out of trials because we're protecting them. But in reality, suicidal individuals may be deprived of access to effective treatments tailored to their needs. And so if we revisit what has happened in the past, and when I look back on this, it's like, don't we really learn from what we've done in the past? So it wasn't that many years ago that it was routine that women of childbearing years were excluded from trials. Just routinely excluded. Why? We were protecting them. It was after the thalidomide problems, and so we just made a decision that we were going to protect women and their unborn children, and they were not going to be in trials. So what happened? We developed a trials literature on middle-aged men. And what we found out is that that literature actually doesn't necessarily just directly apply to women. And so women at some point got up and said, wait, we want our own trials. And so the group, and I'm making this pitch because I actually think that if we're going to move forward, where this has to come from, unfortunately, is for the affected population to speak up. So women of childbearing years said, give us our own research. The same thing happened with children and adolescents. Children and adolescents were excluded, and we just took what we did in adults, treated children as though they were mini adults, and applied the trial's results to kids. Didn't work. And so now we must say, if we are not including children, the world has gotten turned on its head, we must say why we are not including children. And the same also is true of ethnic minorities. When we developed the regulations, we were very concerned about one group or another being overrepresented in research and exploited simply because they were a captive audience. And so that came from abuses in the past. And so we routinely were careful to not have too many minorities in our research trials. And so what happened? We don't know very much about ethnic minorities and how medications and psychotherapies function differently. So I guess what I would say is that in order to achieve change, we have to accept risk. And that activism by the affected group with support from the research community, to me, seems like the way to go. And this is why I presented the information about HIV and AIDS. And if you look at what that community did, it is astounding. By standing up and being counted and speaking up, they got increased funding. They have a faster review by more than a half of their grant applications on the subjects. There are more effective treatments developed rapidly, and there is a decline in the death rate. So what's the downside of this? You have to cope with stigma, both the individual and the family. And so if you remember back to when AIDS came on the scene, what it meant was that I lived in New York, and so in New York it was a lot of gay men stood up, identified themselves as gay, and said, we don't want this anymore. We want research. We are not going to wait. We demand research. But it meant that they had to lose their anonymity. They had to, from their perspective, they had to identify themselves as a part of this class. And so activism involves a certain loss of anonymity and privacy. With that, and I think that this is one of the problems, particularly with suicidal behavior, there is shame for the affected person, and there is blame that people have to deal with if you are a family member. And I would say that counteracting stigma begins at home within the mental health professions. And I'll just give you an example of something that happened at my institution just a few weeks ago. I was sitting at a lunch after a large talk. The talk was in honor of somebody who had been an esteemed colleague who had died. And the family members were there honoring this person. The speaker was there giving a talk in his honor. And we were sitting around talking about why it was that mental health research didn't have as much funding as other fields, other areas of medicine. And people were saying, my colleagues were saying, well, the reason probably is because mental illness has a stigma and attached to it, and people shy away from it, they don't talk about it, and so we need to really work on decreasing stigma. So I was sitting there with my jaw hanging open because I've been around this institution a very long time. The person who was being honored had committed suicide. Not one person ever mentioned that this person had been taken by mental illness. And so if we can't say that ourselves, how can we expect anybody else to? So I would say what I would want is I would want a bunch of pioneers Suicidal individuals, families, and researchers who are willing to accept the risk in order to move forward. So I'm going to end by this. Aside from a crazed sheep every now and then, this is a very risk-free profession. If you are doing research in this profession, in our profession, on suicidal patients, it's not risk-free. If you are reviewing research where you are accepting that people can do research with suicidal individuals who are in treatment trials, you are accepting risk. So I would just end by saying that in order to move forward, all parties must accept and share some level of risk. The institutions, the institutional review boards, the researchers, the suicidal individuals, and family of suicidal individuals. Everybody has to accept a different type of risk, but if we don't, we're going to keep those suicide rates at a flat line, and we're not going to move them downward. Thank you.
Thank you, Dr. Stanley. We can now take a few questions. Please remember to move to the aisles to the microphones with your question, and don't be shy. And while people are moving, I have a question. You spoke eloquently about the need for affected individuals to make a case for inclusion in research studies. I wonder what you could tell us about what's happening at a national level from national professional organizations or other groups of researchers.
Where actually I see the most activism is from organizations that are by people who have had family members who have committed suicide. And so there is a suicide prevention advocacy network and the American Foundation for Suicide Prevention, and those organizations seem to be making the most efforts. National Institute of Mental Health has moved forward with trying to help investigators with guidance about how to include suicidal individuals. But it's the people who have had family members lost to suicide, I think, that have done the most speaking out in this area.
And what do you see happening in terms of the national organizations that set standards for local institutional review boards? Are they addressing the issue at all?
No.
Okay.
I mean, there are a set of regulations that, we all follow, and because all interpretations are local, it depends on the local institution and their interpretation of and their risk. Actually, it's their risk aversiveness. I was at an NIMH workshop a few years ago, and there were two people who were invited to the workshop, and we all kind of walked away holding our heads because the workshop was there to look at how do we include suicidal individuals in trials. And one was an attorney, and the other was an insurance expert. And basically, they told us we were nuts to think that we would do that, and that they recommended not doing that. If we wanted to be protective, which is what their business is, that we wouldn't do that.
Okay, thank you. Let's take the first question over here.
I got kind of a set of questions. What I'm wondering about the social taboo in our culture that keeps people from really talking about anything much these days is kind of an authoritarian rise. What we've done is an awful lot of stress work over at Bastyr University that I think coincides with the work you're doing. In other words, I'm working two tracks with PTSD. One, physiology, the other, psychology. And I'm concerned because I got a lot of young 20-year-olds over in Iraq committing suicide right now or coming home. The third question is, don't you think if basically we reinstated standards of privacy protection in our computer systems and in our society, that people would be more receptive to working in the system? What I'm seeing is a hell of a lot of people driven away from the system because suddenly they're research subjects and no one's told them. It creates a factor, a wave, It just passes through the networks that we're not going to use the system if you're not going to protect privacy. And that's something that I'm very concerned about, especially here.
Yeah, well, those are good points. The privacy issue, of course, is very important, and it's one of the things that we have to deal with in research at all levels. And it's not just in having to do with computers and protecting things in that way, but it's also just with records in general. And the first point I don't think I got a question from, but the second point about people who are coming home from Iraq, who are suicidal, who have attempted suicide, who will in the future attempt suicide or commit suicide, or for the soldiers who have committed suicide already there, it is a huge issue. And I think that we are just beginning to see the problems there. And so hopefully, if we will be able to continue to work so that we can help. I mean, that's what, as one researcher, that's what I can do.
Next question.
So presently, the IRB won't allow the trials, right, with suicidal individuals, like for experimentation?
No. There are trials with suicidal individuals here. Some institutions will not. My institution has allowed it. I'm doing a trial with suicidal individuals. Marcia's doing trials with suicidal individuals. But other institutions won't, or they put restrictions on who can be in it, how you can, how long somebody can stay in it, what are the criteria for withdrawal, that it kind of threatens the validity of the trial.
So are the 30 studies like increasing then? Or are we still getting data even though it's not like totally what you want?
I think that they are increasing. And it's a few years ago, actually one person at NIMH, Jane Pearson, who is a project officer for me and I think for Marcia Linehan too, is the head of research on suicide interventions, and she took a very active role and proactive role in terms of trying to figure out, okay, so how do we do this? And I think that helped things go a long way. Plus, there were a few people in particular places in the federal government that had a keen interest because suicide was very personal to them, that helped get the ball rolling. So I think it is escalating a little bit.
Do you see the future as like a good increase of more research? Do you think it's plausible or?
Yeah, I do. I wouldn't be doing this if I didn't, yes.
Good.
Okay, we'll take a question here and then we'll go over here.
Hi, my question is, you looked at, in your research, the comorbidity of alcohol abuse, and I was wondering if there was also going to be research with chemical abuse in general. I know that that's also taboo, but I was curious if there were going to be trends in that, maybe.
In terms of doing research with people, actually there's a lot of research, treatment research with people who have problems with substances. There is less research with people who have problems with substances and who are suicidal. But what is interesting about it, when I went and I looked at, well, who is really at risk for suicide in terms of which substance they use, I was really surprised that alcohol is the major substance. There are others that are also there, but they really fall quite a bit below alcohol.
Thank you.
Hi, my question is about how is like Britain and the EU handling this issue? Because I know when the black box warning came out, it was actually Britain that forced the FDA to even approach this as an issue. And so I was wondering what other G8 nations are doing to deal with this.
I think that probably in the United States we use medication more with children and adolescents. So I think that they probably are doing psychotherapy and in the way that they have for the most part. And so they were leaders, if for pushing for this, but I don't think it has affected them in the same way that it's affected us in the United States.
My question is twofold. First of all, in light of all the social stigma around suicidal individuals, could you please say a little bit about how you find participants for your trial? And the second part, if you're familiar at all with the rate of individuals who are suffering from suicidal ideation, et cetera, seeking help on their own. If that made any sense.
Seeking help on their own, meaning?
Seeking help for their depression, for their suicidal thoughts.
Is your question how many people who have suicide ideation
go
for treatment?
Yes, thank you. That's much more understandable.
Yeah, so for the first part, the way that we find participants for our research is we're known. And really, at this point, they find us. Actually, I hate to say this, but these are the kind of patients that clinicians don't want in their private practice. And so we get lots of referrals. The researcher down the hall from me who is doing research on generalized anxiety disorders and has a nervous Nelly in his office, is going to have a harder time getting patients for his research because clinicians in the community find them easier to treat, and so they find us, and clinicians know of our research and they refer to us. I don't know the number of people who have suicide ideation, but I do know that there is a large majority of people who, prior to killing themselves, are not in treatment and have not sought treatment, say, in the year prior to this actual suicide. Where they do go is they go to their doctor, they go to their general practitioner, and a large number of people go to their internist, and then nothing happens and they go on to commit suicide. The other thing that I can say is that there's a large percentage of people who appear in the emergency room for a suicide attempt that then walk out of the emergency room, with a referral, who never then go to treatment. And so there is this kind of a sinkhole in between being suicidal or making a suicide attempt and being in treatment.
So do you have any concerns about the gap there, the amount of people who are attempting suicide but don't seek help versus the people in your trial sound like they are seeking help? Do you worry that there might be a gap between those two populations?
A big concern, and we are now, the next phase of research that we're doing is a treatment engagement project where we're trying to go to the ER and see if we can't develop like 15-minute interventions for helping people assess what are the pros and cons of going into treatment. So to help them get motivated to seek treatment or to continue treatment. And there is a kind of there's an issue that we can't address, which is a larger issue, which is the continuity of care. And so handing somebody who is really in trouble a referral card is probably not enough. And even my small intervention about trying to help people motivate themselves to get into treatment may not be enough. But we are trying small steps, but it's definitely a huge concern.
Thank you.
We have time for one more question.
Hello. I, for many years, worked with the Seattle School District with adolescents, and many times I worked with students that were suicidal. I never knew less than 3 children that were clinically depressed. One of the problems that I found was I worked with people that speak English as a second language. When I referred them to get help, there was no culturally relevant group or agencies that could actually help them. And I'm not going to name the ethnicity, but there was this one girl that had definitely attempted suicide. She was put on the 72-hour watch and wait and all that kind of stuff. And when she finally, I had to track down a person that was of her same ethnic and language group, and the person told me that was just like crying out. Our people actually don't do that. And so one of the problems I saw was, or one of the questions I have is what's being done on a national level to get more inclusion for people that are both ethnically and linguistically diverse.
Yeah, that's a great point. One of the things I can tell you is that in every grant application that you write, that you submit to the federal government, is you must say what your plan is for having a diverse participant population in your study. But beyond that, so you are obliged. I mean, there is a kind of a sense that this is important, but one of the other issues that I think is really important is what are those treatments? How do we know what is relevant? And so we're in a little bit of a bind because we don't know what works generally, never mind beginning to like tweak something or tailor something to a specific population. But one of the things that we're doing, for example, is there's a high percentage now, and it's a rise of young Latino women who are attempting suicide. And so I'm working with somebody now, and we're developing an intervention that's specifically tailored to Latina females. So it's, but it's hard because usually the way, and maybe this is actually not the right way to go, maybe you just have to kind of start anew. Usually the way that treatments have developed is that there's a treatment that has shown general efficacy, and then people take it and change it so that it's adapted to the population. But it could be that we just should totally start from ground zero and just develop totally different treatments.
Well, thank you all for your questions, and join me again in thanking Dr. Stanley.
Thank you.